I am a cath lab tech. I'm Sarah Krause. I work at Advocate Aurora Health in Wisconsin. I'm going to be presenting a percutaneous embolization of a coronary artery to pulmonary artery fistula via the radial artery. So this is a 51-year-old gentleman that presented as an outpatient with ongoing shortness of breath and chest pain for several months. Risk factors included hypertension, dyslipidemia, tobacco use, and a premature family history of coronary artery disease. We did an echo which showed preserved LVEF, a significantly dilated right atrium and right ventricle with no pulmonary hypertension or ASD. We also did a TEE which ruled out ASD as the bubble study was negative for early and late bubbles. Nuclear stress test showed no significant ischemia. So we started the patient on a beta blocker and IMDR. However, he continued to have significant symptoms. So we decided to take him to the cath lab for a diagnostic angio. Our diagnostic angiogram revealed no significant obstructive coronary artery disease. However, we did find, connecting the proximal LAD to the pulmonary artery, a large fistula. At this point, we consulted a pulmonologist to rule out a pulmonary etiology, and it was found to have no parenchymal disease in his lungs. We also consulted surgery, however, the patient declined surgery as a closure option. So we proceeded with a percutaneous embolization of the fistula. We advanced a 6 French XBLAD 3.5 guide, and due to the severe angulation and takeoff of the fistula, we initially wired the LAD, which straightened it enough that we were able to wire the fistula. We then IVISed the fistula to see the size, and mid to distal IVIS images showed a 3.5 to 4.0 vessel going to proximal up to a 7 millimeter vessel. We then advanced an 018 ProGrit catheter over the wire we had placed in the fistula, and we started distally. We deployed 3 4.0 by 13 centimeter coils, followed by 2 5.0 by 16 millimeter coils. During our deployment of coils, we continually used angio to confirm that we were not into the LAD, and we had a safe margin between the ostium of the fistula and the LAD. At this point, we were okay with having a few millimeters between the coils and the ostium, so we deployed our final coil. Final angiography revealed no flow in the fistula. We continued to watch this for over 25 minutes to make sure that there was still no flow into the fistula and that the LAD continued to have TIMI 3 flow. We took multiple views, again ensuring that the LAD had significant flow all the way to the apex and that there was no flow in the fistula. There's another view. You can see there's TIMI 3 flow. On follow-up visit at the clinic, the patient reported complete resolution of his symptoms. He had no more chest pain, no more significant shortness of breath. And at 6 months, we repeated the echo, and it revealed that the right atrium and right ventricle had normalized in size. Thank you.
Quick question: What coils were used, and was there any discussion on which type of coil to use in this particular case?
So we used the RCIS 18 coils by Terumo. That was what we had available at our lab, but due to the hydropolymer jacket and how they continue to expand, we felt that that was the best option in order to occlude that in one sitting.
So in general, there's kind of three types of coils. There's bare metal coils. Those are excellent for small vessels that you need to occlude, particularly distal wire perforations, because they go through an 014 microcatheter. But in something that's a little bit bigger and that's going to be under higher pressure like this, the coils that I think are most beneficial are either the bioactive coils that have the expandable gel like the Azure CR coils do, or a fibered coil that can induce thrombosis. And I think you're going to get a much better seal and plug in something this size.
It's a great case. Sometimes you have to approach these from the right side, depending on where the connection is, because sometimes the angle coming off the coronary is really tough to wire. And so we've done a few of these coming off the PA and been able to coil them from that side. But no, this is a fantastic result in a pretty challenging case with a great outcome, it looks like. So congrats.
Thank you. Thank you.